Okay, so let's go to interaction of weight and diabetes state charts. In fact, it might be in my list of recently open models. Okay, no, okay, here we go. Interaction of weight and diabetes state charts. Okay, and here we go. And here's Melbourne. Okay, there we go. Okay, so ladies and gentlemen, this model was very similar to the model we built up in this class in its original conception, but it ended up going in a much more intensively sort of health economics direction. So I just want to show you a few features to keep in mind here. So first of all, at the main point of this class in Maine, you will find stocks and flows being used to accumulate QALYs and accumulated costs, both in a discounted and undiscounted fashion here. And you will, moreover, see information that is captured on incremental cost effectiveness ratios if you use one of these outcomes here. And it is a, I think it is, yes, it's this reduced overweight incidence ICER. So this is computing an incremental cost effectiveness ratio in the context of comparing the baseline with an intervention that reduces overweight incidence, okay? So if you go up here, you'll see that the becoming overweight intervention coefficient changes from 1, which indicates to use baseline values, to 0.8, which to indicate a 20% reduction in overweight incidence, okay? And based on that, this thing is actually performing an incremental cost effectiveness calculation within the model. Now, I would be happy to, or Dylan, and I think Annie was there for that too, would be happy to help you, guide you as to where this, exactly how this is performed. But if you hold down your key, it doesn't allow it there, within that context. But if you go and you look at the functions here within the context of of this particular experiment, there's a perform ICER calculation that actually does the incremental cost effectiveness calculation here, and it adds it to the outcome. So this model will run the model many times. It will run it, perhaps, I think we set it to run it, okay, here it just did it twice, but in general we could run it 100 times or what have you. And for each of those pairs of runs, it's going to run a baseline and an intervention, take the incremental difference in terms of these costs and QALYs, and it will perform an incremental cost effectiveness ratio from them, okay? How is that done? Well, let's go down, let's just drill down in terms of the activity-based costing here. We have some costs that are being accumulated here in terms of the states that people are in. My other model that I provided to you, which I think is called Basic Health Economics, something in the list of models, it actually takes into account costs, episodic costs too, costs associated with particular events, things like a kidney transplant has a cost associated with it. Here the costs are borne by states. That other model has costs for interventions as well. Here we're just capturing costs for states, and we're capturing quality of life for states. And what we have here is, in person, we have a vector of quality of life for diabetics for different states in which, different weight states in which they could be located, and for normal glycemic people for different weight states. And we have similar cost profiles on a per year analyzed cost. And that is used to compute total annualized costs and quality of life for that person, and those in turn are summed up within Maine across these QALYs. So here the new QALYs are given by the total QALYs across the population, and this total QALYs across the population just calls a population statistic, which is located in here. It's a statistic. You've defined statistics before here in terms of counts. And here, the statistic is such that it's a sum of quality of life across the population or total annualized costs across the population. And that's used here to do the total costs and to do the total quality of life across the population. Those are integrated up or summed up across time to get QALYs into cumulative costs in the discounted versions of them. And those are indeed what is used in the incremental cost effectiveness ratio. So that was a bit of an orientation with respect to that. Yes, question?
The question, in terms of you showed at the start, basically, that it ran two system setups and compared the two in terms of incremental cost and incremental effects. Are each of those specified as separate experiments, is it?
No, they're under one experiment. So one of the things that we will cover this afternoon, based on the show of hands, is something called a parameter variation experiment. And to this point, until now, when we've run an experiment, it's run the model once, okay? And that's very common for exploratory use. But in general, if you want to produce results that are robust, given the variability of different runs of the model, because there are stochastics within the model, you want your findings to be robust in light of those stochastics. You don't want them to be, to see findings which are just a fluke of the happenstance. You ran it once and you happen to see this, to overinterpret that. So to secure robustness in that context, we run the model many times in what are called Monte Carlo ensembles. So we'll run the model again and again and again and again and again. And that's what's going on here, except with a twist. Not only is it running the model with a certain scenario many, many times, the baseline, but it's running an additional scenario many, many times, to wit, the intervention. And for each of them, it's accumulating the results. So you have a set of results that are specific to the, and it's in here, you have a set of results which are specific to the baseline in terms of cost and QALYs, and you have a set of results that are specific to the intervention. And you may be running the model, each baseline and intervention, each 100 times, and you have these pairs of them, right? And you're going to compute the incremental cost effectiveness ratio across these pairs, take into account the cost and QALYs of the baseline, the cost and QALYs of the intervention. You're going to compute the incremental cost effectiveness ratio for each of these 100, and you're going to plot it out in the CE plane.
So basically,
yeah.
In addition to kind of the variant parameter stuff, but in terms of being able to compare between intervention and control, this basically, within the one experiment, run one system, store the results, then run the second system and store the results, and then compare the two?
Sort of. They actually run at the same time in most computers.
So you've got two concurrent simulations running in the one
For most modern computers, they're running at the same time physically.
Okay, and so basically, if I just look at this particular one, that does that, so I can just see how that's set up. Okay.
That's right. And there's an even more extensive model in terms of exploring the health economics side, which is available to you in some parts of it are brought out in more detail. In terms of the other models I provided you, and that's provided in this basic. It's in hybrid models. Sorry, it's under hybrid models. Basic health economics (ABM). This has also a quite detailed representation of the health economics. With here, take into account aspects of intervention costs as well as episodic costs associated with end-stage renal disease. So between those two models, you should be able to get an idea of sort of basically how the costs are accumulated, how the quality of life indicators are computed, and then how those are how those turn into these aggregate costs across the aggregated summed up costs across the population, summed up over time and across the population. These guys here. these qualities and life years lived, undiscounted costs, discounted costs, and then those get used in the experiment to perform the incremental cost effectiveness ratio, running it many times. And this afternoon we'll be doing that. We'll be not the incremental cost effectiveness, but we'll be running a model many times and presenting the results to capture the variability. Okay? Okay, great question. Any other questions about that? Okay, so that was that health economics components. What I'm going to do now is to take stock. We have so I'm gonna close all here, and let me just see, because I know there's some additional components that may be of interest. So just along the same lines, I just have so many models these days which I've demonstrated. There's one called, in what I've given you, called longitudinal data on smoking history implementation science elements. And maybe we could open that up, because this is an important one to take into account. So it's called longitudinal data on smoking history implementation science elements. Do you see that? Mm-hmm. Okay. If you could download that and open it up, that will provide some additional sort of bits related to implementation. So I don't know the landscape here in Australia, but in North America, there's a lot of attention these days paid to implementation science. Dissemination and implementation is a key step within securing benefits from health interventions. It's not just about the design of the intervention, it's about actually realizing it, how quickly it has effect, how sustainable it is, the level of resourcing required to get into effect, the scaling of it, factors such as that. Within that context, there's dynamic models have a big role to play, because they provide great tools for looking at those issues. After all, dynamic models look at processes over time. They can help us clue into how soon we have effect. One of the most tragic things that can happen to a successful intervention strategy is it gets cut off before it's had time to show effect, right? You have a great idea and it's put into place, and it becomes political fodder, and it needs 5 to 10 years to have effect, and it's cut off after 3. And they say, well, it's not working. Well, it's not working because it hasn't yet, the pathways yet haven't had a chance to play out fully. And we can capture those things with a model. But more than that, ladies and gentlemen, we can capture those effects of human resourcing needs, of costs, of sustainability in terms of, say, tax on sugar-sweetened beverages, subsidizing physical activity. We can capture some of the effects in terms of scaling within models. And so one of the things I did here is, this has a rather, this again is a training model. I think I demonstrated it in Melbourne here. And here you have smokers, and they have smoking history, and we actually keep track of their occurrences of smoking, the years that they've spent smoking. This would be very similar to if you want to keep track of cumulative obesity years or what have you, time if last quit, etc. But we also have heart disease, and there's an impact on heart disease risk in terms of the hazard of heart disease developing based on how long someone's been a smoker and their current smoking status. But within this model, ladies and gentlemen, we further have a representation of an intervention as mediated by intervention implementation. So if you go to main, you'll see this components here of associated with scale-up of an intervention. So we have, the idea here is that we have peer educators, and these peer educators, in order to start influencing people, they need to undergo some training, And to train those peer educators, we need trainers who have a higher level of expertise and understanding of the health context and so on. So we have sort of trainers in training, and then trainers who are now deployed who can train peer educators, and these peer educators then go off and they can start to influence people in terms of cessation or in terms of discouraging uptake of smoking. So this is all in Maine, and it's linked in with the costs. So this model also has, health economics components, accumulated undiscounted costs, for example, associated with this. And these peer educators, training them and training the trainers for them, that imposes some costs that are part of the picture. But then there's some costs per year from health services as saved by getting, in terms of associated with their smoking behavior and heart disease. So here we have this cost per year which are exerted by a person. And here, in terms of someone's initiation, for example, we have initiation of smokers that's based on an age-specific initiation hazard rate, and we have cessation rates here that are based on current cessation hazard. And the current cessation hazard here is affected by a baseline cessation hazard plus an influence of peer educators. So the more peer educators there are, the more, the lower will be this, the higher will be the cessation hazard. Yes, Colin.
I'm fascinated by these models. A couple of questions. One is, can you measure, I suspect you can, intervention fidelity through these models? So one of the key things is you've got an intervention that works in an RCT type environment.
Right.
When it comes to scaling up, you want to be able to preserve that intervention effect.
Right.
The more trainers potentially that you introduce, the more potential you've got for reducing the intervention effectiveness. I'm guessing these models you could probably model that in to try and capture the dilution perhaps of the intervention.
Right. So that's a really interesting question, really interesting comment. So I must confess that dilution effect isn't one that I've previously been aware of, and I apologize for my lack of knowledge. I appreciate you educating me. That's really interesting. And yes, you could capture that there's some effect of scale in terms of the number of educators here. So if we have, peer educators in training, the more trainers there are, the more there might be a loss of capacity to really deliver the intervention as it was designed to be delivered. And so there might be some, as you say, sort of a fidelity. I mean, a crude way to do it would be based on the number of trainers, there'd be a fidelity coefficient, right? So if you have 10,000 trainers, there's probably been a loss of, think about sort of, telephone tag or whatever, a loss of fidelity to the message, a loss of fidelity to the original vision and to the plan. And so there might be a fidelity effect that's a function of the number of trainers that would then affect kind of the effectiveness associated with each peer educator, right? And you could capture that, the effect of that in turn on, if you go to person here, you could capture that effect in turn on the cessation rate through this current cessation hazard. Now we would not merely have for the cessation hazard, not merely have some fixed beta per peer educator that enhances this education hazard. Rather, there'd be some fidelity coefficient, and that fidelity coefficient would decline with the number of peer educators. Alternatively, another crude way you could have it would be you have an effective number of peer educators. So there's a certain number, but take into account the fidelity coefficient, you could treat there as being sort of an effective number. So they're half as effective, so you count half the number. But of course, they're exerting costs based on the full number. So you wouldn't want to do that. Yeah, you'd want the full number and then a coefficient, and you can include that coefficient here. I could see that as being quite a nice little effect, and it could be captured. And Jeff or I could talk about that some. There's certain words like coflows or other system dynamics elements that we might want to use to capture that really in a very nice way. But yes, it could be captured, and it would help understand the scaling behavior and adverse scaling.
The other
Yeah.
comment that came to mind in the model is taking cardiovascular disease as an outcome. One of the key things in EPI is trying to determine an individual's absolute risk. So
Right.
you're combining a set of risk factors, which might be waist circumference and smoking behavior,
Right.
Diabetes risk,
Sure.
and combining those into an absolute risk of cardiovascular disease events
Yeah.
in a subsequent period of time.
Right.
These models would be helpful for doing that as well, I guess for blending the risk, because ultimately it's the absolute risk that you're interested in. And there are efficiencies in doing that because you're not treating individual risk factors separately, so it's treating
Right.
blood pressure separately from
Right.
high blood sugar, for example.
Right. Yeah, that's very interesting. So if I get you right in that, there may be certain treatment or intervention strategies which would simultaneously be addressing multiple of those risk factors. So that would lower the lipid profile and lower the adiposity, but more increased physical activity, which would ripple through to several pathways of affecting heart disease risk. I suppose things like smoking, in as much as it's a risk factor for diabetes, which further imposes glycemic through glycosylation, other pathways, it influences heart risk. You could, by stopping someone from smoking, be helping along several pathways ultimately. And yes, you could, sort of multi-pathway effects like this, you could definitely you could definitely capture, and in fact that's one of the real strengths of the model, that you can capture these ripple through effects along multiple pathways. It's not clear to me that the models would be a very good tool to derive it's an interesting thing. Could you use them to try to identify some sort of risk metric, propensity score or something like that for individuals? I need to think about that one, but it seems to me, in as much as they're inclusive and they take into account a variety of factors, because this model here, we have it here, but we could plop it into a GIS environment too, a GIS environment that would have physical activity components, and that would affect the heart disease because of proximity to parks, etc. And so it would have multiple pathways to this, right? Or we could put in a diabetes state chart, just like we saw in the last model, put it in here, and that would have an additional pathway through to this. So yes, they'd be inclusive in that regard, and I could imagine real use to that, of having those components in. Jeff and I have been, for a while now, trying to figure out ways to make AnyLogic more modular, so that you could put in, this goes along with some of Chris's comments earlier, so you could kind of put in modules for diabetes, put in modules for smoking, and maybe have those modules evolve over time so you can get an updated module that has a better representation of certain aspects of smoking. But yes, I could imagine the model being quite inclusive, and it could really get at sort of several factors. And this is one of the reasons I put this, for those who are more from biostatistical perspective, I put this in this sort of framework which harks to sort of survival analysis or competing risks analysis, where you have a heart disease hazard that is contributed to by several different betas here. This one is not quite as nice as some I've done, but the point is that you could have multiple, in a multifactorial disease, you could have multiple contributors to this hazard rate. Yeah. Other questions about this model? Intervention science components with with these training of peer educators and and the trainers. And of course, having done that, ladies and gentlemen, running it, what you're going to see over time is there's going to be some time to have effect to lower heart disease because it takes time to ripple through the obesity or the smoking side and to get people to quit. And that's going to only over time lower the heart disease burden in the population. But another effect of this is going to be, that effect of the timing is, it's going to take time to train the peer educators. So the number of peer educators is only going to rise with a certain rate. And here are a number of peer educators who are being deployed, who are actually in the field. And those peer educators are working to influence, individuals in the population to get them to quit. Smoking, and meanwhile, this population, some of them are starting smoking, some are starting as former smokers, and we have some individuals in the population whose hazard rate is being, people in the population, their hazard rate is being affected by the peer educators. Implementation science components, a very important consideration in certain fronts. I love Colin's idea of sort of looking at the scale-up behavior, and I think that's really interesting. It opens a whole new appreciation, and I could see a model like this being really well suited to that.
It's one of the, if you're taking a drug to market, you don't have to worry about that issue. But if you've got behavioural focused interventions, that's actually a key consideration for scaling up is how you can maintain that fidelity.
And I guess even with a drug, to the degree there's compliance issues, right? To the degree they're really taking it on the accorded schedule, on the at the dosage requested or what have you. I could imagine real challenges for that. I know I've done a lot of work in the TB area, particularly for our Aboriginal population, and one of the most senior people in Canada was telling me that, for years and years and years, they focused on education as the means to success, to get people to, and directly observed therapy, to get people to take drugs. And the thought was that directly observed therapy was important for lower educated people, to make sure they take the drugs. And then there was an incident in our province where someone came into the emergency room with active infectious cavitary TB, I think, which exposed a whole lot of the staff there, including doctors, nurses. I think there were some residents who were exposed. And so they prescribed them all prophylactic anti-TB treatment. So chemoprophylaxis, I don't remember if it was isoniazid or what, but they prescribed them this, and all the people said, well, we'll take it. We know how important it is to prevent drug resistance and to take it. And I guess none of them continued, more than a third of the way into the course. They just refused to take it beyond 3 months. They said, look, this is absurd. I don't like taking it. It makes me feel lousy. I'm not going to take this anymore. And he said, if that's happening to people who run the emergency room, the nurses, the residents, they all know the risks. They all know the regimen. It's supposed to go on for 9 months, and they just bawl. Compliance is a major issue, even for the most educated, I think. Maybe especially for the most educated in some cases. In any event, models with implementation science components are extremely important and valuable, and are very comparatively rare. This is an area of contribution which is wide open in the literature, and unfortunately, for no good reason, it just hasn't been well explored. We've had some models which do this published as far back as 15 years ago, but for some reason people haven't put the effort into it that they could, and it has very big implications. And I think this is an area of real growth in the modeling area. Okay, let's see, additional components that we might incorporate in the model. Just thinking here, in terms of, well, if anyone wants to see it, there's a model that I've provided to you. I know some hands went up for the issue of the presentation for care and so on. I think it's in the here it is. Primary care social support. This is an area of great significance, and it's an area I think again is wide open and very important. So, ladies and gentlemen, this one is called primary care social support, and if you open it, one of the things you'll see is that it's a GIS model. And we're going to have to be careful about running it because it is, I think it is at scale, and it's going to have to read over the network. Yes?
If we're downloading that, there are 5 things in the folder. Do we just download all 5? Or?
I would download the whole 5, and I apologize. It's going to take a little bit of time. I'll demonstrate it here. You can download it, and if it has to go over lunch. So here you'll see, yesterday we acquainted ourselves in maps with the fair city of Melbourne. And here you see before you another fair city, a city down under, a city of Saskatoon. And within this context, we have this model captures aspect of care seeking, and this is based on a model by eminent family care practitioner and researcher Kurt Stange, who's at Case Western Reserve University. I'm privileged to call Kurt a collaborator and colleague, and within this context, I want to distinguish this model through one feature. We have a presentation of individuals for care with in this model to primary care physicians or specialists. The model was designed to look at what Kurt calls this paradox of primary care, which has to do with the fact that if you look at condition after condition after condition, let's say kidney disease, heart disease, diabetes, certain mental health disorders, what have you, case after case after case, the studies have demonstrated that people are conferred better health benefits for that disease by treatment with a specialist compared to treatment by a primary care physician. However, in countries and other jurisdictions which have higher levels of primary care doctors compared to specialists, the health outcomes as a whole are much better. Much better. And Kurt cites cases in Europe, for example, where they have way more primary care doctors and specialists compared to in the US, and the health outcomes are much higher. So he was asking, what is the cause of this? So he built a model which he contributed, and we extended that model very significantly, with Dylan playing a key role in this, and with Jeff and I helping to shape some of it. The primary care specialist division is reflective of the fact that primary care doctors have several advantages. They cross multiple conditions. They manage the patient through their life course. They're more likely to understand the personality characteristics of a patient. So if a patient comes in complaining of pain, for example, a specialist isn't sure how to evaluate it because they've never seen this person before. A primary care doctor may clue in, this is something I've never seen before with this patient. Let me really look into this. The primary care doctor has continuity of care on an ongoing basis, and they can manage interactions of drugs across multiple conditions and better understand the patient barriers and context. So Kurt's model made a first stab at this, and Dylan's model, which Jeff and I helped shape, further influenced this. And one of the real innovations of this one is Dylan incorporated this representation of what Jeff and I have a conviction is a key component, which is the role of informal caregivers. We know that particularly in older age, regardless of society, the informal caregiving network is an absolutely key one, and of course in youngest ages as well, for shaping care outcomes for individuals. We also know it plays a central role in terms of cost and quality of life profile for patients, and that one of the big reasons for institutionalization of an older individual, for example, is the fact of burnout by the informal caregivers, or the fact that they can no longer logistically care for this person because of the level of special needs for this patient. So if you can strengthen this informal care network in terms of education, but in terms of respite care, in terms of providing them a chance to have some time off from the caregiving responsibilities, if you can provide them with the extra support they need physically to deal with this loved one, you can sometimes forestall institutionalization by years, which can offer very material benefits in terms of societal costs, but also enhance quality of life for that individual who is cared for. So Dylan put in this informal caregiving network here that accompanies a primary patient, and that serves to mediate the effects on that patient's health status associated with some of these interactions with primary care physicians, etc. And Dylan has two simulations. Dylan uses good and to the point naming. There's a fast simulation and pretty simulation, and I think they stand for themselves. But fundamentally, this model captures the interactions of these patients and their informal caregiver networks across multiple conditions with primary care doctors and with specialists. They present for care, they undergo treatments, they undergo observation by their doctors, etc. And this is all in a GIS environment, which in this case, for informal caregivers, is arguably in the world quite important, because if a person is sent to a long-term care facility following discharge from acute care that's far from their informal caregivers, it can really lead to a deterioration of their condition and quicker institutionalization ultimately, or permanent institutionalization. So here, ladies and gentlemen, we have GIS components represented, and Dylan has represented it. It looks like it's taking a while. My machine is pegged in terms of dealing with this, but here it is, I think, dealing with a lot of GIS cache data and so on. So this particular model might be of interest to some people, particularly those interested in the service network context. There's food back there? Okay. There's another model. I'm not sure if it's a member of the ones I've uploaded, the Vortex model, which I'd like to show, the health vortex, which should be interesting to include. I think given the food is there and this is taking some time to run, I'll just leave this running and we can see it up on the screen during lunch. But lunch is served. We'll eat here, and I think we'll reconvene in 45 minutes, okay? And we'll try to deal with some others of these prioritizations. Thanks very much for your patience.